Welcome to St. Petersburg.
Thanks very much. Quick introduction to my team. On my right is Dr. Ishwar, Ginny, and Mr. Shedge. So these are the team members who would be seen involved in this case today. We will have a quick glimpse of the case. Can we have the case, please?
The world outside may change with the first light of dawn or the twilight of dusk, but inside Poona Hospital, it is always bright as day. To enable those inside to continue with their never-ending endeavor to fight disease and illness. The hospital's doors are open to all, working towards the motto of your health and well-being through our skill, care and compassion.
That's the team. This case is of a 58-year-old gentleman who's a diabetic and a hypertensive, admitted just last evening with acute inferior wall myocardial infarction.
Okay.
And can we actually run the angiogram? The angiogram in the slides, please, not here. Yes. It showed that there was some left main disease. There was significant disease in the mid segment of the LAD, and the right coronary artery was the culprit with thrombotic. Show us the right coronary artery, please. There is a clear disease at the ostium of the LAD. This is the right coronary artery. Huge thrombus burden, a proximal lesion, ostial lesion, as well as a lesion before the crux. So yesterday we did the angioplasty. Can we just stop here? Our plan was to actually discuss a few things. The first being, in a humongous thrombus load like that, would you do a primary thrombus extraction? And second would be, would you address the left main disease and the LAD disease at the same time as primary angioplasty? And the third issue would be, because we had planned to do the FFR of the ostial LAD disease, what are the values to be taken into consideration of the FFR value on someone who has been pre-treated with ticagrelor? That was the third point. And the fourth point was, can we take the help of IVUS to decide and further validate the results of FFR? So I would probably at this juncture invite a few comments from the panel and the chair, please. Thank you.
Thank you very much for joining us today. I'm Greg Caluza, co-chairing with Jack Lewin from New York. And we have Dr. Quesada. We have two colleagues from India also, Dr. Kahali, Dr. Parchouri. We have colleagues from Russia. So why don't we just start with Dr. Quesada.
Good morning.
Good morning.
Thank you for a great case. Regarding the first question, patient has come with a STEMI with a lot of thrombus burden in the right coronary artery. Even though we know from the data that thrombus extraction is not going to change the long-term outcome of these patients, it really do help to improve our short-term technical aspects. So in a patient such as this with a large thrombus burden, I definitely, in our practice, still perform thrombus extraction. Sometimes when it's a short thrombus and it's a fresh thrombus, less than 12 hours, we use a catheter extraction. All thrombus, more than 12 hours, 24 hours, 72 hours, we definitely prefer to use mechanical extraction with angiojet, for example.
So in that case, do you go ahead as a case for primary thrombus extraction, or you would do that only if the balloon dilatations fail to achieve what you actually desired?
You know, we still use, in a case like this, I would use primary thrombus extraction only to facilitate the procedure.
Okay. All right, so we will run through that angioplasty. Can you show the next pictures, please? We have done the angioplasty of this gentleman, and we have fixed the proximal thrombotic lesion and the distal lesion at the crux. Put in 2 stents 2.75 by 22 integrity distally, and 3 by 34 resolute integrity proximally right up to the ostium and post dilated with a 3.5 millimeter balloon. We had a very adequate result yesterday evening, and this is what is shown here on this picture. Can you see this one, please? We can switch over to the lab now. Lab pictures, please. So that's the result that we had yesterday, and we have checked this once again this afternoon when we started this case this morning. Can you see that on your screens there, please? Can you hear us?
Yeah, we see the final result.
Okay. Now we moved our attention to the left main and the LAD lesion. So this is how it looks today. There's a clear dampening of the pressure when we engage the left EBU guide catheter, which is a 7 French guide, but there was significant pressure drop. Next, please. That's the lesion in the mid segment of the LAD, and the FFR was done, which was significantly abnormal, so we decided to stent this. But you can see that there is some lesion in the proximal segment of the LAD, as well as the left main is diseased. Please quickly run through these. Next. Next. So that's the 2.5 by 22 millimeter onyx stent, post dilated with a 2.75 up to 14 to 18 atmospheres distally and proximally. So that's the result that we have achieved. After this, we have done the FFR of the proximal LAD as well as the left main, and the value came, what was the value, Richard? Ishwar, what was the?
0.75.
And that was with what dose of
That
adenosine?
was with 150. We started with 120 micrograms, and then the dose used was 150, where we got the value of 0.75.
What do you think about the dose of adenosine in someone, and what should be the route of administration in someone who has been pre-treated with ticagrelor? Any comments about that?
What was the FFR again? I missed that part.
FFR after having stented the LAD was 0.75 at the intracoronary bolus of 150 mics, did you say? 150 mics.
So, you know, that now we have current data of comparing IFR versus FFR and which way you go. Usually it's the opposite. When the IFR is in doubt, we go ahead and do FFR. Now, here the left main looks diffusely diseased. So if I still have a doubt of the FFR, I definitely will. I was the FFR and prox. I was the LAD prox and the left main before making a final decision.
Absolutely, I agree with you, and that's exactly what we have done. So, Vishal, can you please take us through the IVUS of the stented segment of the LAD and the proximal unstented but diseased segment of LAD as well as the left main, please. Please play the entire run right from the beginning. Can you see the IVUS images on your screen there?
Yes.
Okay. That's just beyond the stent. You can see the stent here. It seems fairly well opposed. You can make your comments about the IVUS in case you would like to, please. So before we actually complete that run, how many of you would have done this left main stenting, or if it comes to stenting, we don't know still, or actually fixed the LED yesterday itself? So how many of you would have done a non-culprit vessel angioplasty at the time of primary angioplasty? What's the opinion of the house on this?
Yeah, sometimes if the patient is stable, we go for it, but I think we could have waited for this patient, so I support your approach.
And we support the approach of evidence in the literature as well.
I think you have the data to support you
Yeah.
to go ahead with total revascularization at the time of the PAMI. If
Only
the
if.
patient.
Yeah. Go on.
Second thing is, for your FFR, you actually are looking at the combined LAD and left main disease together.
Yes.
So you can't really specify that you're looking at the LAD FFR.
Absolutely.
Second thing is, you have a diffusely diseased LAD, there's a disease in left main, and probably there's a disease at the bifurcation as well.
Yes.
So IVUS or OCT or any imaging system is very important here.
Yes. So that's the complete run of the IVUS that you just saw. Any of you can make a comment before actually one of us makes a comment about what our findings are on the IVUS. So do you want to take a call on what IVUS shows? We can tell you the diameters. I think the LAD ostium measured 2.6 in the cross section area, was 2.6 millimeters. 2.5? 2.5. And the proximal part just after the ostium was 2.9 millimeters, and the left main was, what was the cross sectional area? It was 5. So the cross sectional area of the left main was 5 millimeters. Any call, any take on that? No, I agree. Somebody just made a comment about having seen the disease not only in the LAD ostium, but also the left main. So what do you do in a situation like this? In case of FFR, I think best is to take a pullback gradient along with the FFR, because it is going to measure a combined FFR of both these lesions. But we haven't taken a combined, we haven't taken a pullback gradient here. But that's a good point, that we need to take a pullback gradient in a situation like this. So any comment on the IVUS, please?
So the IVUS is giving you the data that you need. You have a left main that has an area of less than 6, and we all know that less than 6, if you compare that to medical therapy, revascularization has a better long-term outcomes. That's number one on the left main. Number two, you have also disease at the ostium of the LAD and prox LAD with significant area. If you were measuring the areas of the left main, circumflex ostium, and bifurcation circle LAD, you have to have at least more than 4 in both branches. So you have the diffusely diseased left main, ostial, ostial LAD and prox LAD. So you already stented the LAD. My comments will be that if you are going to evaluate the entire left coronary system, and the lesion in the mid-distal and the distal LAD was angiographically estimates at least intermediate lesion, I would have evaluated the whole entire left system prior to intervening in the LAD distal. And why is that? Well, because if you do a full evaluation of the left main, you want to make sure that you need to intervene in the left main LAD, or the surgical option. We now have data on left main intervention. If you have a syntax score that's more than 30, then probably you should withhold the intervention in the left main LAD.
What was the diameter of the left main?
So that gives you more options. All I'm saying is that functional evaluation is mandatory, as you mentioned, of the left coronary system, left main LAD, but to make the full decision, do it all at one time. So now you're dealing with left main prox LAD, and you already committed to the distal LAD. So what is the next? Definitely you have severe disease. Most of my patient. And now you are addressing a complex intervention in the left main LAD system, and that is a very difficult decision today. We're going to have a whole discussion tomorrow about this, but this is life. Now, what are you going to do?
I think from what you said and what I understood is that we need to fix this disease in the proximal part of the LAD as well as the left main.
This is a classic example of whenever you see osteal disease of the LAD, it's not a LAD disease, it's a left main LAD disease.
Correct.
You have proven that by showing that the IVUS.
Yeah. Small test.
So if I can make one quick comment, as you just said, osteal LAD disease is really left main disease where the largest plaque burden is the osteum of the LAD. But the left main here is extraordinarily short. From a practical standpoint, it's impossible to treat them as two separate lesions.
Inflate.
You can't stent an osteum of the LAD and nail it. There's no such thing as precision stenting the osteum of the LAD. So for already carrying it into the left main, and given the short length of the left main, you might as well stent from the osteum left
Oh, that was good. That was good.
to the LAD.
Come back.
There's no practical way to separate the two. Yeah.
I hope you heard that. I would give a lot of attention to what Gary has just said about it.
Yeah.
It will depend. Outcome will depend on what he just said.
Can you summarize that for us? Because we just lost you for 10 seconds in between.
The left main is so short that it is, for all practical purposes, impossible not to treat this as a single unitary system of disease, and therefore stent from the ostium of the left main into the proximal LAD. You cannot separate the two.
Okay, so we have a 38 millimeter.
Overlap it with the.
All right. So can we have a 3 by 38 onyx, please? What was the diameter, Vishal, of the LAD? What would you recommend a stent size for the LAD?
See, I would be very careful if I'm going to put a stent which is less than 3 millimeter diameter in LED, I'll question myself.
Sure.
Am I doing the right thing?
Sure. Yeah, but it looks like Vishal is measuring it to around 3 millimeters. 3? Okay. And the left main?
Left main is around 3.5.
Okay, so the left main would measure approximately 3.5 and the LAD 3 millimeters. So what would you recommend the size of stent to be? 3 millimeters? 3 millimeters by 38? Can we have the stent, please? Onyx 3 by 38 onyx.
330.
Yeah. So we are doing a provisional stenting here. Do you agree with that? We don't have to have wire in the circumflex at this stage.
I would have loved to see a pullback from circumflex into left main to have a look at the ostium of the circ, which I will decide on. If the ostium is free of disease, I'll not wire it.
Yeah. So
We can instead, since we are short of time, we can instead show you the elaiocaudal view.
the data, regardless of what it looks like
Stop.
angiographically, because the
Go back.
angiogram is totally unreliable,
Yeah,
is
I
that
agree. I agree.
disease at the ostium of the circumflex in this situation is variable. It can be negligible, it can be relatively significant. And the only way to know for sure is to image the circumflex directly.
Okay.
I think we completely agree with that. I think if you're going to intervene and you're going to treat the left main LAD as a single vessel, that's what you should do. You need to make sure that the ostium of the circ is free.
Okay.
If the ostium of the circ is free and it has an area of 3.5 or more, then you have it's a different different complexity of lesion.
Okay.
You're talking about provisional stenting and the left
So
main LAD.
I'm going to
If
take
it's-
this stent out because I had decided to stent this across the circumflex. Since the opinion of the house is that I should image the circumflex, I'm going to wire it and put a IVUS catheter into the circumflex. Is that right?
That's what we're saying.
Okay, no problem. Let's do that.
I think Gary has shown many times that even if the Marina classification angiographically is 111, when you put the IVUS down, LAD and circumflex, it changes. It changes dramatically. So you cannot see only on the basis of angiographically what the disease in the circumflex is. It has to be IVUS or OCT, whichever you use.
Okay. Can you give us the elaiocaudal view?
So, when we're talking about left main and what they're working, the syntax classification is really not doesn't give us all the answers, and I think tomorrow we're going to have a lot of discussion about this.
Test.
But we have to see if the lesion is complex or simple. If it's a complex lesion, then it's not a provisional stenting strategy anymore. It becomes a two-stenting strategy, and you need to know that up front. That's why it's so important imaging in the left to improve the outcome.
Absolutely. So how many of you at this stage would think that depending upon the angiographic findings, that you would find a significant disease at the ostium of circumflex? How many in the panel feel that we are likely to find significant disease at the ostium of circumflex?
I mean, there's going to be plaque burden at the ostium. If you talk about the data that Sujin Kang from Assam Medical Center generated, that significant disease is defined as a plaque burden more than 50% and a lumen area less than 4, and it's probably relatively low. But if you talk about at least enough plaque burden to worry about it and protect the circumflex with a wire as you do crossover stenting, then the odds are probably high.
Just showing you the pullback at the ostium of circumflex now. Can you do the pullback for us, please? Yes. Start now. Yeah. Go on.
So immediately you see that the circumflex has a
proximal plaque,
not insignificant plaque burden, although we're really mostly concerned about what it looks like at the ostium.
It's almost at the ostium right now.
We're still in the circumflex.
Yes, still in the circumflex. Now coming pretty close. Yeah.
So
that's it. Yeah. So what do you think of the plaque burden at the ostium of the circumflex now?
I think you're safe.
Okay.
But you also notice how short the left main is.
Yes.
It's maybe a couple of millimeters long.
Absolutely.
So your 2 or 1 stent strategy depends on the pullback from LAD and circ both into left main, right up front.
So here, shall we go ahead with 1 stent strategy now that the circumflex ostium is not looking too bad?
Yeah, 1 stent strategy is all you need.
Okay, thank you.
For the audience, this is important. When you're doing a single strategy, you try to size the length of the stent to the prox LAD, and then you're going to do at the end proximal optimization, making sure that the marker of the balloon proximal is at the carina. So you open the struts of the carina and don't compromise the circumflex, and that will allows you to minimize the chief.
Can you show the LO caudal?
Chief flaking at the ostium of the circ.
By the way, 1 small point. When he imaged the ostial left main, notice that he had retracted the guiding catheter, so that we saw the transition from the left main to the aorta, which is really important.
Yes.
Because otherwise you're not sure what's going on.
Absolutely, absolutely.
May I have a question from the audience?
Yeah.
We are dealing with a middle-aged man who had diabetes mellitus and left main disease and truly triple main disease, and his acute coronary syndrome was fixed successfully yesterday. So why not to consider surgical treatment thereafter? What is the indication to treat so complicated issue the day after the acute coronary case? Thank you.
Any of the panel wants to answer that, please?
This is the diabetic patient.
Yeah,
with
no, I understood your question.
vessel
Small test, small test.
with the left main, ostial circumflex, LAD disease, and his
Epicranial.
coronary syndrome was fixed successfully yesterday. Why not to consider surgical treatment for this patient?
I will tell you what the indication was, but I just want to have the comment of the panel.
It's a totally valid viewpoint.
Yeah,
I think
absolutely.
anything else, it depends on the
test.
patient, the skills of the interventionalist and the surgeon. I'm not sure what you do with the right coronary, though, because you obviously would not bypass it because the graft won't stay patent. You've already stented it. So this is really not, if the patient had presented with stable angina or unstable angina without a STEMI, without a thrombus, and didn't have primary PCI, I think your argument would be a lot stronger. But at this point, you're dealing with a patient who, bypassing the right is not going to do much. The graft won't stay patent. The circumflex is borderline as to whether it even needs to be bypassed. You're talking about putting a lima to the LAD, which is totally valid. I don't disagree. I think, we don't have great data for this particular subset. We have much better data on patients who present with diabetes through unrevascularized three-vessel disease.
I think this is a real live case, and I think it emphasizes the implementation of the heart team approach for left main disease. And I think your point is very well taken. A patient came with an acute ischemic coronary syndrome. The infracranial vessel was treated. Now you find that the patient has intermediate disease and the distal LAD has disease, definitely disease that needs to be treated, revascularized, and the left main proximal circ, the left main is short, as we mentioned. So what to do? Is the patient stable enough to warrant a discussion about the case? Of course. And that depends on the experience of the operators and the experience of the team and how to decide. But I think after all that has been said, I think this is a suitable patient for left main LAD intervention.
Exactly.
I entirely agree. It's a very valid question you've asked. In day-to-day clinical practice, you have dealt with the right coronary artery lesion, which has caused the MI. And now what you are left with is a residual syntax score. I think one of the panelists touched it. But what you're left now with is a residual syntax score. So what Gary Mintz has just said is very important, that it's a day-to-day clinical practice you have dealt with, because you couldn't have done the syntax score at the time of the PAMI.
Big Mac, please. RAO caudal. 3.5. Please get me a 3.5 millimeter NC. LAO caudal.
I suspect the left main stent is somewhat underexpanded.
Yes, we are taking another larger sized non-compliant balloon. Give me a 3.5 NC, please. Sure.
So the question from the audience. I would like to ask, why did you leave with the wire from the left circumflex? Why didn't you left the guide wire and then?
It does not have a big advantage really to leave it in.
Anyway, in IVUS, as you can see, there was some plug burden. So
I don't think I had doubts that I won't lose it. I was pretty sure that doing it without having a wire in the side branch was still possible.
So now you think that the pot is needed now?
Yes. Yeah, inflate. 12, 14, 40. Come down. That's a 3.5 millimeter NC balloon. That was the proximal part of the LAD as well as the left main. I will now do the ostium of the left main. Inflate, please.
I'm going up 40.
16,
16,
18, and
18.
come down.
IVUS.
We can have the IVUS now, please. Can we have the IVUS?
This way. Okay. I was ready. Just this has to be wiped. This is good.
The lights, please.
We can go FF for run as well.
Yeah. We can go AP cranial, please.
Yeah. Reset. Yeah.
Yep. Can you see it on the screen, the IVUS? Post
Yes.
dilatation.
Adenosine 150.
Okay. This reorganize. There is some malapposition. Minimal. No. Looks okay. Looks okay.
Remember, malapposition has never been shown to be important.
Okay.
The issue is the area of the stent, the minimal stent area,
Yes.
in the various segments of the coronary.
We are into the left main now. Almost. Not yet.
Not yet.
There, see the circumflex coming in at
Yes.
5 o'clock.
Yeah.
Now we're into the left main. The left main, you should, ideally the left main should be at least 8 square millimeters.
Yes. Can we get the area of that left main?
And cover the ostium in this case, which it does.
Can you get the area of the left main?
Right. How many presentation now we have? 2 or 3?
Proximal LED MLA.
Quickly tell us the area of the LED as well as the area of the left main.
FFR.
Just a little more on 5, 6, 5, a little more.
German.
Yeah.
I think you should do a proximal optimization.
A little
of the
more?
left
Yeah, that's what I think, because I've just been told that the area is 7.5 millimeters. So go.
And then
yeah.
remember, you have to put the marker or the distal marker of the balloon at the carina. So you have so you expand the struts and open the ostium of the circumflex. You don't have
Perfect.
So you don't have obstruction of the
4
circumflex.
millimeter by a sharp
That's very
8.
important. There's a minimal details that help you to achieve the best results.
Absolutely.
4.8.
Yep. So we'll take a 4 millimeter by 8 millimeter euphora and see. Quick. Come to the epicaudal view, if you can.
Okay, we are a little behind schedule. Thank
That's
you very
fine.
much for
Yeah.
bringing this very relevant and real-life case to us today from India, and we'll let you finish this off in peace. Thank you very, very much for your contribution today.
Thank you. Thanks
And
very much for having us.
Next time. Thanks.
Bye-bye.